registrar presentation for this week. I'm Sean Griffiths, and today I'm presenting on meniscal root injuries. To begin with, the anatomy of the menisci. They're C-shaped cartilage discs that fit between the tibial plateau and the femoral condyles. Macroscopically, they've got anterior and posterior roots, capsular marginal attachments, and accessory attachments in the form of the transverse intermeniscal ligament and the meniscofemoral ligaments. Microscopically, they're fibrocartilage dominated by type 1 collagen fibers, arranged randomly, radially, and circumferentially. They act to increase joint congruity and hence distribute forces over a wider area, along with providing a secondary stabilizing effect to the knee. Their cross-sectional wedge shape also means that they can take axial forces and convert them to hoop stresses that are then resisted by the circumferential collagen fibers and their root attachments to the tibial plateau. This in turn overall decreases the forces that are seen between tibial and femoral articular surfaces. The pathology that's seen with a meniscal root tear is a radial tear through the meniscus within 9 mm of its insertion, or an avulsion of that bony insertion. Overall, 2/3 of these occur to the medial meniscus, and a significant fraction of these are degenerate in nature. Degenerate tears primarily affect the posteromedial root due to its more rigid native attachment. The remaining 1/3 affect the lateral meniscus and are often related to sports or other general or higher energy trauma. Meniscal root injuries are relatively common if a knee dislocation or a multi-ligament knee injury occurs. Iatrogenic harm may occur to the anterior medial or lateral roots, particularly during ACL reconstruction if tunnel placement is too anterior, or tibial nailing if the entry point is too posterior. Pediatric patients are typically seen to have root tears in the setting of sports injuries and are typically seen as a cluster of injuries to the knee from an indirect force. This imaging demonstrates a posterior horn medial meniscal avulsion. The healthy function of a meniscus is dependent on it having strong attachments, so it remains between the femur and tibia, and so that hoop stresses can be dissipated by the circumferential fibers into the tibial plateau. Loss of continuity of these fibers in any way leads to loss of these functions, and in turn there is decreased contact areas by approximately 50% and a resultant increase in forces between tibial and femoral articular surfaces by up to 300%. These changes in turn lead to cartilage degeneration and osteoarthritis that's rapidly progressing. Some studies have suggested that spontaneous osteonecrosis of the knee, or SONC, may be a sequelae of a meniscal root tear or a complete radial tear with resultant loss of meniscal function. Peak loads increase and then produce the microfractures and resultant osteonecrosis that's seen in this condition. Progression to an end-stage osteoarthritic joint that requires arthroplasty is reliably and rapidly seen as seen here. While exact numbers vary with the time frame and publication in question, the overall natural history is reliably poor. The most common classification system used is that of Laprade, published in 2015. This was developed from a series of patients undergoing arthroscopic assessment and is primarily for intraoperative grading and guiding of management. It divides tears into 5 grades, with grade 2 having 3 subtypes based on its distance from the footprint. Preoperative MRI findings may give some indication of the grade or pattern of injury, however will not be as precise as arthroscopic findings. Grade 2 was the most common in the initial population. The grade of the tear doesn't directly correlate to clinical outcomes, as management choices and long-term outcome is also influenced by condition of the knee in other ways, such as other ligament injury or cartilage wear. Forkel and Peterson added some detail to root tears affecting the posterolateral meniscus by considering the integrity of the meniscofemoral ligament. As seen here, the anterior and posterior meniscofemoral ligaments run medially from the posterolateral root, anterior and posterior to the PCL, to attach onto the medial aspect of the femoral notch. These provide supplemental stability to the lateral meniscus and may remain intact despite a root tear. Type A has a root avulsion and type B has a root tear, while both retain intact meniscofemoral ligaments. Type C has a root tear and a deficient meniscofemoral ligament, which could either be a discrete lesion or a tear lateral to the meniscal origin of the ligament. The net effect that they found was if the meniscofemoral ligament remained intact, the meniscus and knee was relatively spared from the consequences of a root tear. Bear in mind that approximately 7% of patients have no meniscofemoral ligaments, and the anterior meniscofemoral ligament, which is visible on arthroscopy, is present in only a minority of patients. These are outputs from pressure transducers within porcine knees in various states and are very cool depictions of the science and physics occurring within the knee. Of course, these are knees from quadrupeds rather than bipedal humans, so the mechanics are different, but it does give some indication of the protective effect of the meniscofemoral ligament. The top line is the medial compartment pressures with an intact meniscus in A, then peak loading in the center of the articulation when a root tear is present in B. The bottom line shows the lateral compartment pressures with an intact meniscus in A, then a root tear but an intact meniscofemoral ligament in B. We can see that there's minor increases in force. Finally, in C, there's both a root tear and a deficient meniscofemoral ligament, and again we see that central peak loading. History and clinical exam, as always, should be our first point of investigation for knee pain, where there may be a suspicion of meniscal or meniscal root injury. History should focus on mechanism, particularly where it's identifiable for acute injuries, given that association with certain mechanisms and concurrent injuries to the knee. For subacute or chronic injuries, functional impacts and complaints may be more easily identified. As seen here, no one examination finding is diagnostic. The constellation of a positive McMurray, joint line tenderness and pain through flexion activities would markedly increase our index of suspicion, although this is not necessarily specific for root tears versus more general meniscal injuries. In the setting of an ACL rupture, if the pivot shift and Lockman's tests are more strongly positive, this can suggest loss of the lateral meniscus posterior root function with its secondary stabilizer function. This increases our suspicion for a posterolateral root tear. Of interest, mechanical symptoms such as locking, catching and giving way are not quoted as being strongly associated with root injuries, so if present, they may direct our suspicion towards meniscal body pathology. The classic MRI finding is the ghost meniscus sign, where on scrolling through sagittal slices, the meniscus is initially present, then disappears or fades as a radially oriented tear lies in a similar plane to the slice or slices in question, and then reappears as you scroll beyond that area of tear and retraction. These slices demonstrate a ghost meniscus sign on the sagittal slice, while on the coronal slice, the truncation sign with the absence of meniscus is indicated, and the axial slice demonstrates it as being a radially oriented lateral meniscal root tear. Root tears are generally best appreciated on T2 sequences, where a bright fluid cleft is visible where the dark meniscus should otherwise be. Meniscal root tears are also associated with seeing extrusion on coronal MRI slices due to the force redirection from the wedge shape, along with the loss of tethering, which then allows the meniscus to be squeezed out from between the articular surfaces. These images demonstrate a meniscal root tear with resultant extrusion of the medial meniscus. The degree of extrusion is measured as the distance between the peripheral margin of the meniscus and the peripheral edge of the tibial plateau. The threshold for this is typically quoted as being 3 mm. MRI detection of tears is obviously dependent on the slices in question, the quality of the scanner, and the experience of the reporting radiologist. While highly specific, and it has been quoted as up to 100% positive predictive value for a tear if seen, sensitivity has been quoted at between 60 and 93%. Even on retrospective review of preoperative MRIs with arthroscopy proven tears, only 50% of missed tears were identifiable. As such, a certain index of suspicion must remain in the right clinical scenarios, particularly in this setting of injuries that are associated with a root tear. A thorough examination using the Mark I eyeball and probe should be performed whenever arthroscopy is being carried out. These pictures from one of Laprad's publications demonstrates a posteromedial meniscal root tear and the instability that's visible on probing. This is the algorithm for treatment choices from JOS in 2020. Regardless of the algorithm you choose to use, the basic question is whether there are clear contraindications to repair, and if not, then you should repair the meniscus. Those contraindications are primarily issues that mean a repair will fail, such as concurrent pathology or tears through the rest of the meniscus, unaddressed instability or marked malalignment through the knee, or degenerative joint disease with arthritis or subchondral collapse that means the knee will progress to end-stage osteoarthritis regardless. Obesity and malalignment are relative contraindications, but both should be addressed on an individual basis and can be addressed perioperatively. As mentioned, untreated instability would be a contraindication, as it also is for other meniscal repairs. As such, and given that many root tears occur in the setting of an ACL rupture or multi-ligament knee injuries, these patients should then undergo reconstruction and repair concurrently. Ultimately, the question is whether surgical repair will succeed and can we improve the natural history for the joint in question. What's not mentioned amongst these is the Laprade type 1 partial tear where the meniscus is not unstable. Management for these is much less discussed, but it could include debridement of torn edges to minimize the propagation of the tear, ensuring not to iatrogenically convert an incomplete to a complete tear, or repair and stabilization may also be attempted. One of the first repairs described was the transtibial pull-out technique. This diagram demonstrates it with a Laprade 2A tear that has had two sutures pass through the torn end, then pass through a tunnel in the tibia and progressively tied over a button on the tibial cortex. As far as achieving the initial suture placement, some articles state that while the locking loop and simple cinch give better pull-out strength than a simple suture, the number of passes and perforations required for the locking loop construct make the cinch overall the preferred pattern for securing the torn end of meniscus. An alternative technique has also been described using meniscal suture anchors, such as fast fixes, to get secure suture fixation through the meniscus, and then maintaining the long end of the suture to pass down through the tunnel. The tibial tunnel can be planned making use of an ACL drill guide jig to assist with placement, and the tunnel then drilled. Sutures are passed down the tunnel and cortical fixation is secured with a button, screw or other technique. Some authors do describe using two tunnels to allow tying over the bone bridge rather than over a button. The main downsides of this technique are the potential to under-tighten and not achieve stability or hoop tension, over-tighten the suture and then pull the meniscus into the tunnel and shorten it, the tunnel interfering with other tunnels that might be required in the setting of ACL or multi-ligament reconstruction, or finally the bungee effect, where there's more movement at the root due to the length of suture available to stretch if you then compare it to a suture anchor technique. As depicted here, suture anchor fixation can be used to secure the meniscal root to its insertion, and the length of construct is much shorter to minimize any bungee effect. However, getting access to the posterior tibial plateau and being able to drill holes for the anchors directed anteriorly is technically challenging and puts a variety of neurovascular structures at risk. As such, multiple different techniques, including accessory scope portals, or working through the femoral tunnel in the setting of an ACL reconstruction have been described. The fact that multiple have been described suggests that none of them are actually optimal. Some studies have suggested equivalent overall outcomes between those two techniques, and as such, the JOS summary article from 2020 recommends the transtibial technique due to its use of familiar approaches and instrumentation. This demonstrates a technique for fixation and stabilization of a lateral meniscal posterior root tear done in conjunction with an ACL reconstruction and making use of the tibial tunnel. This was initially described by Forkel and Peterson in 2012. This is useful in that while ACL ruptures may often have injuries to either medial or lateral menisci, if a root injury is present, it's most likely to be the posterolateral root which is involved. As seen in the first intraoperative picture, the root footprint is A, heavy suture is passed through the avulsed or torn root as B, and the root itself is seen as C. This is then passed down through the tibial tunnel tagged D, securing the torn root to its footprint at E. This is depicted diagrammatically on the right, showing the relationship between the secured root tear and the ACL graft, tunnels, and fixation. Repairing a root tear in the setting of ACL reconstruction has the benefit of regaining that secondary stabilizer effect of the meniscus, as previously mentioned with regards to that pivot shift and Lockman's assessment. Post-operative rehabilitation, of course, is crucial for success. This protocol is from the Archives of Bone and Joint Surgery in 2018. Of note, it will override any standard ACL rehabilitation protocol if there is that concurrent ACL reconstruction, with the expectation that final outcomes will be better despite the more restricted early phase. The initial 6 weeks of non-weight bearing are particularly to protect the meniscus from hoop stresses being transmitted through to the healing root. Some authors then advocate a period of partial weight bearing until 8 weeks. Deep flexion is minimized early to minimize the femorotibial contact pressures and any translational forces. Non-weight bearing range is progressed, and then finally loaded deep flexion is the last activity to be recommenced due to it applying the most pressure through the knee and the menisci. The fine details of outcomes, of course, vary between the studies in question, but overall they are consistently and strongly in favour of meniscal root repair. PROMS reports are also in favour of root repair as well when compared to conservative management or partial meniscectomy. Cost-benefit analyses also found reduced cost to the healthcare system by meniscal root repair due to the overall decreased or delayed demand for arthroplasty. Patients for whom non-operative management is appropriate include elderly patients with degenerative tears, particularly if there's widespread meniscal degeneration and/or existing moderate to severe osteoarthritis. As mentioned previously, knee instability is a contraindication as the repair will fail. However, this generally just means the knee needs further stabilization procedures performed concurrently. There may be patients for whom this is not possible due to other medical or surgical issues. In these cases, repair should be delayed until all the intra-articular pathology can be addressed at the same time. Non-operative care involves the standard optimization with physiotherapy and symptom management. If the patient is having mechanical symptoms from their meniscal tears, then partial meniscectomy may be considered to address those elements with the understanding of the effect of meniscectomy on cartilage loading. It shouldn't be performed purely for the root tear itself. Ultimately, in the end-stage arthritic joint, which many of these will end up as, arthroplasty may be considered. The choice of total versus unicompartmental replacement will be decided on an individual patient basis. Unicompartmental replacement has shown to be effective for SONC, which in turn is associated with root tears. As such, I would consider it in the correct patient with intact ligaments. So, in conclusion, meniscal root tears are a significant injury that was underappreciated until relatively recently. We need to be alert to them on MRI and during arthroscopic examination of the knee, and wherever possible and appropriate, they should be repaired. The transtibial pull-out technique currently appears to be the most recommended technique for repair, but there are other techniques that can be used in experienced hands. Where concurrent ligamentous injuries to the knee exist, root tears and ligament injuries should all be treated together to give optimal patient outcomes. Here are some of the references for this presentation. Thank you for your time.